Hello, this is Dr. Clark, and we're going to be talking now about fetal circulation. So, if you remember when we were talking about systemic versus pulmonary circulation. Fetal circulation is a little bit different. We still have systemic circulation, but instead of having pulmonary circulation, we now have placental circulation. And so there's a couple of things uniquely different as we look here at the heart in the fetus. And one of them is there's actually a hole right here in the heart. It is named the oval foramen, also known as the foramen ovale. And so this actually allows, when the right atrium contracts, it actually forces some blood over here into the left atrium. So blood actually will pass from the right atrium to the left atrium through this hole. There's also something coming off the pulmonary artery here to the descending aorta known as the ductus arteriosum. So any blood that actually comes from the right ventricle and makes it up here into the pulmonary artery, part of that blood is going to go to the lungs, but a large part of that's actually going to be forced in the aorta. The reason for this is that in the fetus, it's not actually breathing. And so it's not needing to use the lungs for gas exchange. The other thing is too much fluid in the lungs actually causes what we call hepatization of the lung. The lung will actually get too full of fluid. It actually starts to look like liver. The lung and the liver embryologically come from about the same type of cells, and so occasionally we do actually have where these mechanisms don't exist in the fetus, and they're born as a neonate, and they have severe problems with the lungs, and usually they don't live very long because they're not able to breathe because of the way that their lungs are overloaded with fluid. So it has a twofold right here. First off, the lungs aren't needed because you don't have a gas exchange happening there in the fetus. Gas exchange is going to actually happen out at the placenta. And the other thing is too much fluid in there, and you get a fluid overload, can actually cause to misdevelopment of the lungs. One of the things to notice here on fetal circulation is you have the umbilical vein, and so the umbilical vein is actually carrying oxygenated blood, and it's going to come from down here from the placenta up through the umbilicus into the body, and it's actually going to come to what we call this ductus venosus right here. And so this right here is a little collecting pool. You have other blood vessels that are going to actually meet up right in this ductus venosus right here, and it's actually going to go and kind of bypass the liver, and it's going to go on up into the caudal vena cava. So the circulation here of oxygenated blood is a little bit different. It's going to actually come in through the umbilical vein in the fetus, go through this ductus venosus here, and go right on up into the caudal vena cava, and then into the right side of the heart. This means that when the left side of the heart is pumping right here, it's actually pumping a mixture of oxygenated and deoxygenated blood around. And so there's not as high of oxygen tension in blood overall within the fetus. And this isn't a problem because the fetus relies on the mother for several different things. Nutrients is one, oxygen levels are another, so all the breathing and all that goes along with the mother, and warmth. So one of the big things that we talked about with four-chambered hearts is it allows you to control your body temperature a lot easier and a lot better. And in the fetus, mom controls the body temperature. In fact, fetuses and embryos like to live in a certain temperature range. Temperature gets too low, it can potentially cause abortions. Temperatures get too high with fever. I have definitely seen this where we've had abortions, especially in horses. A mare with a temperature of 104, early stage of pregnancy, within the first 45 days, I will promise you that she will absorb or that embryo, that fetus or embryo, or abort them. So the next thing we look at here is the way that the aorta comes and sends out blood, and it's going to send it out throughout the body in systemic circulation, but some of that blood is actually going to return back down the umbilical artery and is going to go back to the placenta where gas exchange is going to happen at. So this is what happens here is the circulation system is a bit different in the fetus because you're going to have oxygenated blood coming back up through the umbilical vein into the right side of the heart. Most of that's going to be shown at the left side of the heart. Circulation from the left side is going to go systemically, and part of that systemic circulation is actually going to go down the umbilical artery. Now, right after birth, and actually it's negative pressure in the chest that starts this whole cascade of changes in the heart, is right after being born, you take that first breath, and that negative pressure actually makes this oval foramen close, and it actually makes that ductus arteriosum close. So both of these actually close off with the first breath. The other thing that happens is after the umbilical cord is broken, this ductus venosus right here, and then the umbilical vein and the umbilical arteries that go along with it, because they're not having blood flow, they actually close themselves off. And so this is actually showing what happens after the fetus becomes a neonate. After it's born and it takes that first breath, it is no longer a fetus, it is now a neonate. So the hole closes up in the heart. This ductus arteriosum closes right here. And then once that umbilical cord breaks, all the blood's pulled out of the placenta. This ductus venosus actually goes away, and so do the blood vessels that go along with it. They actually atrophy and go away. And you go to normal systemic and pulmonary now blood flow. Occasionally we do have issues that come about where this does not actually close. The oval foramen or the ductus arteriosum. And so when these are open, we have in a newborn, you actually have what we call a patent oval foramen. And I've actually heard a couple of these murmurs that can come from either this area or up here at the ductus arteriosum. In horses and foals before. I've also been there when we actually did surgery on a puppy when I was in school that actually had what they call patent ductus arteriosum. So basically what happens is this little vessel right here does not actually go away on that first breath, does not actually close down. And so a lot of blood is still shunted from the right side of the heart and mixes and goes over here to the aorta, and not enough goes to the lungs. And so this is actually a surgery we can easily go in there and fix by actually tying this off. It's a bit harder for us to do this oval foramen if this doesn't close. That's an open heart surgery. They do it in people, but we're not really that good at doing it in animals, plus the cost and the expense of doing it. It's probably not the fact that we're that good. We just don't do them because it would be so costly. This right here, to just ligate that right there, is a couple of $1,000s on a puppy. You go into actually having to open up that heart and try to close this right here, you're past a couple of thousands and you're probably in the tens of thousands. So there's probably some people that do them, but they're not that common. So the next thing that usually happens too after all these close up is that this ductus venosus goes away right here. Sometimes it doesn't, and we get something called a portosystemic shunt because it keeps shunting blood. There's veins that will still hook up, and it'll keep shunting blood right past the liver like it did in the fetus. And once again, if we can find this right here, we can easily ligate and close those right off after they're born. So some signs of a portosystemic shunt's actually going to be right after they eat. They actually get neurological symptoms because of the toxins that actually are made in your digestive system right after you eat. The main one's ammonia from proteins, and so if this is in place right here, this says down here is supposed to be the portal vein. Really what it is this is probably like a piece of intestine, and so some of the blood supply from the intestine normally comes over here around the ductus venosum, and it'll eventually go into the liver after this actually closes down, but part of it bypasses and comes through. And if we have a portosystemic shunt, it goes right past the liver, and it allows this blood from the digestive system that's high in ammonia to go throughout the body. And ammonia is very toxic to the brain, so we end up with puppies that end up in kittens that have this, end up having neurological symptoms. They'll be ataxic, they'll do head pressing, get really depressed, have seizures, potentially can be fatal. We realize what this is. They come in with these signs and symptoms. We do a dye contrast, and we'll see that blood's being shunted past. Or we can look at the liver. The liver is not getting its full blood flow, and so on ultrasound, it's going to be a lot smaller in size, or on radiographs than it should be. We'll figure out this is the problem. We'll locate this and ligate it, and it's fairly easy to take care of when we do that. So here, the next few slides are going to go over what I've already talked about, but you can see that the fetus is receiving oxygen from its mom, so it doesn't really need the lungs. And so that's what kind of makes fetal circulation a little bit different. So when you sit here and look at it, oxygen is going to flow from the placenta over here to the umbilical vein. And then from the umbilical vein, it's going to go through the ductus venosum and up here into the right side of the heart, into the right atrium. It's going to be either pushed through the oval foramen, or it's going to be, the majority of it's going to be pushed through the ductus arteriosum, both of these right here. And from here, it's going to go back into systemic circulation. Very little of it's going to go to the lungs. And so pretty much everything stays the same. Blood enters the right side of the atrium. Biggest thing is this bypass right here. And pretty much most of this I've already gone over as far as the way that it travels from one side to the other in the ductus arteriosum and how it goes to the aorta. And so deoxygenated blood is going to be sent back through that umbilical artery. Said it's not purely all deoxygenated. Some of it's going to be oxygenated. It's almost kind of mixed like you would find in a reptile or a fish. And because of that, fetuses need a lot more support because the blood, the oxygenated and the deoxygenated blood does mix a lot more together. Main thing is after they are born, all of this right here should shut off normally. And then all at once you go back to your normal uh, pulmonary circulation and systemic circulation. So we're going to go here now to heart sounds. And so our normal heart sounds we're going to hear is what we call lub-dub. And so you need to be pretty good at actually sitting there listening at sounds and rhythms to kind of pick up on this. And this is a problem for a lot of students. The best way to figure this out is to actually just listen to every single animal you can. Get out your stethoscope, listen to your animals, your parents' animals, your friends, your neighbors, anything that comes in here to the school. Pull out a stethoscope, listen to the heart. This is the best way to figure out heart tones. So the first sound that we hear is called S1. And so S1 is actually what happens when the ventricles contract. And it causes closure of both the mitral and the tricuspid valves at the beginning of ventricular systole. And you actually hear them snap shut, and this causes a sound that sounds like lub. The mitral valve is definitely the loudest, and it's the most easiest heard on the left side of the chest. To hear the tricuspid, you have to be over on the right side. And so we actually have a little thing that's called PAM 345T. So we can listen to the pulmonic valve on the left side at the third intercostal space. We listen to the aortic valve on the left side at the fourth intercostal space. And we listen to the mitral valve on the left side at the fifth intercostal space. So P in PAM is pulmonic, A is aortic, M is mitral, and then there are rib spacing. Pulmonic's at the third, aortic's at the fourth, mitral's at the fifth. And then we have T. And so T is on the right. So we call it PAM 345T. And T stands for tricuspid. Tricuspid is going to be on the right side. And it's going to be somewhere around that third or fourth intercostal space. It's important when you're listening to the heart to listen to both left and right so you can make sure when you're checking for murmurs that you've checked all your valves and made sure that you've actually listened to them and that you don't miss. If you just listen to the left side of the heart, you will totally miss that tricuspid valve. You can only hear it on the right. Dub is actually going to be the closure of the aortic and pulmonic valves. And you can hear it over on the left side of the chest on both of them. And so you'll actually hear them. So in dogs and cats, you hear this lub-dub, 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 going back and forth, back and forth, back and forth. And so by listening at that, you can actually pick up in a while which one is the mitral valve closing when you're listening to the left side, and which one is your aortic and pulmonic. If you listen over on the right side of the chest, all you're pretty much going to hear is lub, 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 because you're going to hear nothing but that tricuspid valve. Occasionally, if it's a small enough animal, you will hear the dub, you will hear the pulmonic and aortic over on the right side. But for the most of the time, if you get something like a lab or in large animals, all you actually hear is the tricuspid when you listen to the right. But when you listen to the left, you'll hear that mitral, which is lub, and then you'll hear those pulmonic and aortics, which are dubs. In large animals, their heart rates are so slow that you can actually hear a third sound, which is sounds like another dub. And so that third sound is actually rapid ventricular filling. This is actually when the atrium are in systole and they actually contract. You can actually hear the blood being forced down into the ventricles, and it's kind of a dull dub sound, kind of when you hear it. And then in some horses, so S3 sound we can hear in horses and cattle. I've heard it in dairy cattle before that can have heart rates that are in the 30s and 40s. You can hear that, some of them in the 50s. Some really fit athletic horses like thoroughbreds that are in race training, or quarter horses that are used routinely for something like cutting or reining or trail riding, or these endurance horses that are ridden and trained 4 hours a day for these long trail rides. When they're at rest, they'll have very slow heart rates. I've seen them approach rates as slow as 18 and be perfectly normal. And some of these you can actually hear the contraction of the atrium, which is the fourth heart sound, or S4. So a lot of times what you'll hear is lub of the um, tricuspid and mitral valves actually closing. You will hear dub of the uh, aortic uh, and mitral valves closing. And then you'll actually hear another uh, dub, which will be the sound of the contractions of the atriums. And those horses that have really slow heart rates, usually you got to be below 30 to hear it. And then if their heart rates are, say, below about 50, then you'll actually hear the third heart sound, which is another dull dub, which is actually that blood being forced from the atriums down into the ventricles. This is important because when you're listening to to large animals and the heart's beating there, if it's beating at a rate of, say, 20 in a horse, and you're hearing all four heart sounds, if you're just saying every two sounds is one beat, instead of 20, you'll come up with 40. Or another problem we see with horses is that at 36, you can easily hear three heart sounds. And the problem is you can miscount if you're miscounting every two. And instead of coming up with a rate of 36, you end up coming up with a rate of 48 or 54, depending on how you do the math on counting it. So it's important to learn what those different sounds are in large animals. One thing you can do with large animals is their heart's so large that when you cup and hold your hand over the stethoscope, you can also put it up against the chest to where you can feel the heart, and you can physically count heartbeats while you're actually listening to the sounds and figuring out, okay, I've had a beat and I heard three sounds, okay, I'm getting three at a time, and it helps you out that way. Or if they're really slow, like in a big thoroughbred that's really well conditioned, you hold your hand on there and you hear four sounds, but you only feel one beat. So that kind of helps you out. Of course, if they're excited or their heart rates get up a little bit, you'll sometimes just hear the two sounds, and so holding your hand on there will kind of help you learn what those sounds are like and get used to the different heart tone sounds in large animals. Said only 3 and 4 you're only going to hear in large animals, cattle and horses. Everything else you're going to just hear this lub dub, and especially in small animal, this is the sound. Sometimes they can be so fast it's really hard to kind of tell them apart. Because like in cats, if you have a cat with a heart rate of 180, it's really hard to kind of figure out sometimes what is lub and dub. One thing about heart sounds right here is when things go wrong with the valves, this is when we actually get murmurs. So one of the things up here is when we actually have this patent ductus arteriosum, or this oval foramen, we get what we call a washing machine murmur. And we call it that because it sounds like a constant rumble, like the old drum washing machines. And so you just hear this constant. You really don't hear much of a heartbeat. You just kind of hear this constant swirring and wishing sound going on in the chest. If you end up having any type of wrong blood flow across the mitral valve, tricuspid valves, or against the semilunar valves of the aortic and the pulmonic, and so when the heart goes into systole, the mitral valve is supposed to keep, and the tricuspid supposed to keep blood from going back up into the atrium. But if it gets to where those valves don't seal right anymore and they're letting blood leak backwards into the atriums, you actually start to hear a murmur. And that's where that PAM 345T comes in. Very important to know, because you can figure when you listen, okay, I'm hearing a murmur. Where is it the loudest? Is it over the third, fourth, or fifth intercostal space? If it's the loudest over the fifth on the left side, I know that I have a mitral valve problem and I have a mitral valve murmur. If it's the loudest on the right side, I know I have a tricuspid. Same thing with aortic and pulmonic. I know if that murmur is loudest over the third space, I have a problem with the pulmonic valve. If that murmur is the loudest over the fourth intercostal space, I know that I have an aortic valve. And so anytime that blood's going the wrong way, and a lot of times with those murmurs with the semilunar valves, it's the fact that when the valve closes, some blood's allowed back into the ventricles. And so that blood going the wrong way actually is what you're hearing the murmur from. Cardiac output. So cardiac output is going to be the amount of blood that leaves the heart. And there's two things that actually determines this. First is going to be stroke volume, the amount of blood ejected with each contraction of the heart. And the second thing is going to be the heart rate, so the frequency that the heart contracts. And these two things are going to make up your cardiac output. You either have to increase cardiac output and blood circulating in the body, you either have to increase the amount of blood that's ejected each time the heart beats, or you have to increase the heart rate. And so this is kind of the simple math of it is cardiac output is equivalent to the stroke volume, which is the amount of blood being pumped out, times the heart rate, how often the heart's going to beat. Cardiac output is going to increase like during periods of exercise. So when you exercise, the body naturally goes ahead and increases stroke volume and heart rate. Things like fight or flight, pain, being scared, anxious, all these can actually cause an increase in stroke volume and heart rate. Other things that will increase heart rate is going to be compensating for decreased stroke volume. So the body's trying to keep the same amount of blood going out. If stroke volume is not working properly, and it can be for a myriad of problems. It could be because the heart has muscle problems. So what we know is dilated cardiomyopathy, where the left side of the heart or the right side of the heart, the right ventricles don't contract with enough stroke volume anymore. Or in cats with hyperthyroidism, they actually get hypertrophy of the left side of their heart. And so the left side, the muscle gets larger, but it actually shrinks down the chamber size. So if you remember, we were talking about each chamber normally contains the exact same amount of blood. Well, the left will get to where it's larger, but it actually grows into that volume area, and so it actually contains less blood than the other three chambers. And so to make up for this, the only way you can make up for this is to increase the heart rate. Another thing we get is hypovolemia, animals that have had blood loss or fluid loss. There's not as much blood, so there's not as much for the body to push out. So one of the things that we see in early shock and throughout shock is the body increases the heart rate to try to increase the cardiac output. So Starling's laws, one of these laws that we actually have in biology, and basically it's based off of a principle of Starling's law where if you have a vacuum and you open up the vacuum, everything's going to rush in to fill that vacuum. It's kind of the same thing right here. Increased filling in the heart increases the force of cardiac contractions and increases the stroke volume. So the more blood you can pull into the heart and the more the heart contracts, the more volume is pushed out with every single beat. And so we have some things called preload and afterload. So preload is the amount of blood available to the heart. So if your preload is really low, there's not enough blood making it to the heart, that's going to decrease, of course, your stroke volume, such as in the case of hypovolemia, not enough fluid. The other thing is if you have too much pressure on what we call afterload and blood's not able to be forced out, that also reduces your cardiac output because the heart has too much pressure to push against, and so it can't effectively. So both of these things underneath Starling's laws will actually affect how well the heart's going to pump. In normal conditions, the stronger it pumps and the more blood it's able to pull in, the more blood it's going to be able to push out. And anything that starts to deviate from that deviates from Starling's law, and you have issues with cardiac output. Anytime that the blood pressure or the amount of fluid coming into the heart decreases, the only compensation for the heart to do if there's not enough fluid coming in is to try to increase the heart rate. Or if the heart's not able to make proper stroke volume, the only compensation it has is to increase heart rate. We do have something, and we'll get into the nervous system, called the autonomic nervous system, and so it's important to know we have what we call the sympathetic side of it, and this is the fight or flight response. And so in this one here, hormones will be released, epinephrine. There's also another one called norepinephrine we'll learn about. And both of these increase both stroke volume and heart rate. So whenever there's epinephrine involved, stroke volume and heart rate are both going to increase. Parasympathetic, on the other hand, is when you're relaxed. And when you're relaxed, it takes over. And so stroke volume is decreased and heart rate is also decreased. We can actually induce parasympathetic stimulation through things like general anesthesia. There's some other drug sedatives. We can actually induce the parasympathetic side on the heart and actually slow down the heart rate and actually slow down well, not the heart rate. We slow the heart rate down, but we can also decrease the amount of blood pushed out with with the stroke volume with each contraction of the heart. And that's what parasympathetic. So sympathetic is going to speed it up, and it's going to make the heart beat stronger and make it eject blood with each stroke volume in a greater amount. Parasympathetic is going to slow it down, and it's going to let the heart relax a little bit more, take a break, and not have to push out as much blood in each stroke volume. The electrocardiograph, or EKG, this is an instrument to actually sit there and electrically look at the heart. So the body's kind of interesting. It runs off of just a couple of things. And one of them is hormones, and the other one is electricity. And these two things control most of your body, and we can actually look at the electricity. So when we're looking at the heart, we look at the ECG or EKG, which is the electrocardiogram. If we look at the brain, we do something called an EEG, which is an electroencephalogram. Or looking at muscles, we look at, like in Lou Gehrig's disease, how does your muscle actually contract? How strong is that impulse wave? And we do something called an EMG, electromyogram, where we can actually sit there and look at how much electricity is being put out by these things. That's what we do with an EKG. So every time your heart beats, there is some electricity that's put out, and we can actually capture this on a monitor, and then we can actually even transmit this to paper. One thing is, when we diagnose anything on an EKG, a lot of times we can look at the screen, but to do proper diagnosis, it needs to be on paper. But these electrical currents come from the heart. They're going to be measured by what we call leads, and then they're going to be put down on paper. And so this is what we're looking at. And so this is a P, a QRS, and a T. P, QRS, and a T. And so P wave is depolarization of the atriums right here. And so you'll just see, this is on a dog, you're going to see the P wave whenever the atriums contract. And it's kind of small because the atriums aren't as much muscle as the ventricles are. The next thing you see is the QRS complex. And so the Q is the starting of depolarization, and then you can see the wave cross the heart up here, the R back down, and then the S is the end of ventricular systole. So from here to here, the ventricles contract. So the P wave is systole of the atrium, and then the QRS is the systole of the ventricles. Right after that, we actually get something called a T wave, and this T wave right here is simply this ventricles, both right and left ventricles, actually repolarizing, getting ready for the next beat. So after your T, you end up having another P from the atrium, another QRS, and another repolarization of the ventricles with the T. A lot of people ask me, well, why don't I see repolarization of the atrium? It should be somewhere in here. Well, it is, and it's buried underneath the QRS. The ventricles are so large and powerful that they actually sit there and hide the repolarization of the atriums. So you don't actually see that in an EKG, but you will see the T wave where the repolarization of the ventricles is at. When all these are equal to where there's one P to one QRS to one T, this is what we call a sinus rhythm. So it's a 1-to-1 ratio, one P wave to one QRS complex to one T. Normal sinus rhythm means that these are all spaced normally, everything's normal between them, and so that makes a normal sinus rhythm. Sinus arrhythmia, there's still a P, a QRS, and a T. They're all equal. The difference is that the spacing between the R's and the P waves might be a little bit different. See this normally in dogs, and it changes up and down with respirations. It'll go speed up and slow down with inspiration and expiration, and that's actually normal in dogs, some people, and in horses. You can have what we call sinus bradycardia, which is a sinus rhythm where we have all these equal, P, QRS, and T, and it's just slow. And in veterinary medicine, this is kind of relative. So horses live in a state of bradycardia. They have an average heart rate of 36 to 40, very slow heart rate. Perfectly normal for them at rest. What would be abnormal in a horse at rest would be to see a heart rate of, say, 60, which a lot of people would consider closer to a more normal heart rate for a person. On the other hand, when we look at cats, cats live with heart rates of 150 or greater all the time. So in a cat, if their heart rate gets below 120, we start thinking that's getting a little bit too slow. It's getting closer to bradycardia for a cat, but they live in a state of what we would consider tachycardia for people because their average heart rate ends up being around 150 to 180 beats per minute. So it beats very, very fast. So when we look at our species, we can have these variations here in heart rate. So, and I spoke about horses with sinus bradycardia. Said cats live in sinus tachycardia. So everything's still equal here. A P, a QRS, and a T. It's just a really fast heart rate. When we start looking at vascular anatomy and physiology, blood in the systemic circulation is always going to be under more pressure than that in the pulmonary. Part of this is how strong that the left ventricle actually contracts because of the extra muscle. And also, you have to think that the right side of the heart, the right ventricle, is only having to pump blood to the lungs. So it can be at a lower pressure. It doesn't have to be as high because it's going a shorter distance. Whereas the left ventricle, the blood's going to have to be at a much higher pressure because it actually has to make it to the end of your digits, very importantly to the brain, to the kidneys, out to the skin. So it takes a lot more force to push it that extra distance. So there's going to be a lot more pressure over on the systemic side than the pulmonary side. And so when we go to leave the heart for systemic circulation, blood's going to actually exit through the aorta, and it's the largest blood vessel and artery in the body. It has the thickest diameter walls, and the artery walls across the body are kind of similar to the walls inside the heart. They have the same lining of endothelium, just like the endocardium has. And there's smooth muscle in there. They're much thicker, and they actually can help make pulse waves to help push blood along. And so they're also a lot more elastic. They have a lot more elastin to where they can change in size with these muscle fibers. And so vessels, arteries specifically, are able to either dilate or constrict by the body's need for blood flow to a certain area and pressure. One thing is if you dilate it too much, you don't get enough pressure, blood doesn't move far enough, like to the brain. And so you have to put some constriction in there to get enough pressure to make blood actually go to the brain. If you over-constrict things, then you actually keep things from flowing. So it's constantly changing the diameter of those blood vessels, the arteries are, to keep a constant flow of blood through the body with a proper amount of pressure to reach everywhere it needs to. When we look at vascular anatomy coming off of the arteries, you're going to have up here we talked about the aortic arch. They're showing a cat right here. Cats are a little bit different than dogs and people. And so you're going to end up having what they call this brachiocephalic trunk right here. And off the brachiocephalic trunk in the cat, you're going to have three vessels come off. The left subclavian artery, which is going to go out to the left forelimb. You're going to have the left carotid. Excuse me, I was saying left, should be right. The right subclavian is going to go the right side, right limb, the right carotid. And then in cats, also off of this brachiocephalic trunk, you're actually going to have the left common carotid. And then coming around the aortic arch, you have the left subclavian coming off. In dogs and people, actually what you have is the brachiocephalic trunk, which goes to the right subclavian and to the right carotid. And then you're actually going to have the left carotid coming off, and then you're going to finally have your left subclavian. And then the aorta makes a turn and goes caudally, and it's actually going to go down to the hind limbs, to the pelvic area, and it's eventually going to turn into the coccygeal or the tail artery. And coming off of it along the way are going to be things like the mesenteric, cranial, and caudal mesenteric artery that feeds blood to the intestines and the GI system, the ovarian and the testicular arteries, which are going to give blood to the gonads, the renal arteries, which are going to give blood to the kidneys. So you have all of these different ones, the femoral arteries, which are going to give blood to the hind limbs. All these different ones come off of the aorta. And so this right here just kind of goes over what I've talked about already, that the main trunk of the aorta arches dorsally and then travels caudally and then you have these numerous branches coming off until it finally terminates in the coccygeal. Smaller arteries continue to split off into smaller vessels that are stop being called arteries and become arterioles. And eventually arterioles are going to actually go into tiny thin-walled vessels called capillaries. And they're really not even walled. They're just very thin vessels. Most of them are big enough for only 1 or 2 red blood cells to get beside each other at a time. And what's important here is that no gas exchange happens in the heart, in the arteries, or the arterioles. All your gas exchange, all of your respiration in your body happens at the capillary beds. This is where oxygen unloads, carbon dioxide comes on in systemic circulation, where glucose leaves the bloodstream, lactic acid enters. When you get to the lungs, cellular respiration happens where carbon dioxide gets off and oxygen comes back on. This all happens in capillary beds, not within the arteries or the arterioles. And then the blood's going to leave the capillaries after it's gone through the tissue beds, and it's going to go into the venules, which are very small veins. And so these very small veins, once again, once you enter back into these larger vessels, there's no gas exchange in venules, only in capillaries. So once it enters the venules, then it's on the way back to the heart. And then small venules end up networking and branching in until they become veins, and then veins become larger until they actually merge into the cranial and caudal vena cavas. Venous blood is under much lower pressure than arterial blood. That's very important to realize. So there's a definite pressure difference here, and the vessels are much thinner walls. They don't have as much muscle. They have some ability to change in size and dilate, and a little bit to constrict, but not much. So the arteries play a much larger role in constriction and blood pressure than veins do. Veins actually have valves, and so these valves actually are unidirectional, and they make sure that blood travels towards the heart. And when blood tries to go backwards, it actually closes off these valves and keeps the blood from like falling down to your feet when you stand up, or when a horse or a dog stands up. It keeps all the blood from just sinking to the bottom, these little valves. This is why it's important that when we give an injection or we place a catheter, that we go in the direction towards the heart of the valves, because we push those valves open with the catheter or needle. If you go the wrong way, you can actually cut those valves, and if you do, you can actually cause problems with edema in limbs or in specific areas, because blood is then able to go an opposite direction from what it's supposed to. Gravity is actually able to pull it down. So veins are much thinner walled, they're underneath less pressure, and they have these little valves that help ensure that blood doesn't just fall the wrong way. Because all the pressure is on the artery side, and you got to think of how much pressure is absorbed, how much energy is absorbed to push blood through the capillaries. So there's not as much pressure coming back through the veins. And what actually helps to move things through the veins is things like gravity, somewhat pressure, but movement is very important to actually helping pull blood through the veins, and so is the heart beating itself. Every time that right atrium ends up contracting, and then once it relaxes in diastole, it's open, there's nothing in it, and so that kind of creates a suction that pulls blood in. So all these things actually help to pull blood through the veins back to the heart. So I kind of talked about the veins of the forelegs right here. They merge into larger and larger vessels until they get to the brachiocephalic veins, and then they end up coming back in the cranial vena cava. And then the veins of the hind limbs merge and the intestines until they get to the iliac veins for the limbs, and then they come into the caudal vena cava. And then that blood flow from the intestine is also going to come into the caudal vena cava. It's definitely the largest and the one that carries the most blood of the two veins, and the caudal vena cava is going to be the largest in the body, and it travels back to the right atrium. Smooth muscles are throughout all the different blood vessel walls except for capillaries, and so they actually do help control some of the blood pressure and also blood volume. One thing that will happen is if you become hypovolemic, is these blood vessels will all actually try to constrict to try to keep pressure up, to keep blood flow circulating throughout the body. And so that's just a natural reflex that actually happens when you become low on fluids. If you become too low, they constrict too much, they actually stop blood flow to the heart, and people actually pass out from that. Venipuncture sites, so some different areas that we actually go to get blood is going to be things like the jugular vein, the cephalic vein in small animals on the front legs. We can also go to the femoral vein or the lateral saphenous in small animals. To pull blood in like cattle, we can go to their tail vein, the coccygeal. And dairy cattle will actually go to their mammary veins, their milk veins, and actually pull blood from there. One thing to remember is when you're pulling blood in small animals before surgery, we don't really like to go and pull it from the cephalic vein because that's where we usually put our catheters. You want to go to the jugular vein or to one of the veins on the hind limbs. And so this is what they're kind of talking about is the ventral aspect of the neck, the jugular groove. Is where you're going to find the jugular vein. We'll kind of look at that in lab. And one thing to realize is the carotid artery lies nearby. So whenever you stick these, you want to make sure you're in the jugular vein, especially if you're going to be putting in a catheter or you're going to be trying to give any medications, because if you accidentally give it in the carotid artery, that could be fatal to your patient. So you have to take great care to make sure that you're going into the jugular vein. And really, it's kind of hard to get a needle into the carotid artery in small animals. It kind of bounces back and forth. But it can be done. And one way that you'll know is it's going to be bright red blood. And a lot of times if you accidentally hit that carotid instead of the jugular vein, you'll actually see that plunger getting pushed out. And so they talk about the caudal epigastric vein or the milk vein here, which is something that we do in cattle. I've also used it in lactating mares. In some situations, I've been able to pull blood from there. Sometimes in horses, we can actually get to the cephalic vein too. It just depends on how good the horse actually behaves. But sometimes if I have a catheter in a jugular vein, I don't want to damage or just do anything to the other jugular vein, I need to pull blood, then I can sometimes access that cephalic vein on horses, and it's fairly easy to find and fairly easy to draw blood from. Not that easy to catheterize, but we can actually get enough blood to do a CBC or a basic chemistry panel. So that is the end of cardiology, and we will see you in lab.